Mobile Medic for Women by Anthony Burnell, Miranda Kahini, Amy Kane, Sarah Cooley, and Anna Cooper. The homeless population in our country is in critical need of basic health care. Although federal programs are in place to service the health care needs of the homeless, many needs are left unmet due to difficulty in accessing care. While both genders in the homeless population face serious barriers to obtaining care, women have the added responsibility of their sexual and reproductive health care needs. The group has chosen to create a mobile health clinic focused on the prevention, screening, and treatment of sexually transmitted infections, family planning education, and general gynecological health care for the female homeless population of Birmingham, Alabama. The utilization of the mobile clinic will help improve the health for these persons by providing a more readily available source of health care. The mobile clinic will also relieve some of the burden of the urgent and emergency departments in the area. The microsystem consists of the purpose of the Mobile Medic for Women, which is to provide health care for those that would not receive it in any other way. The patients are the homeless population in Birmingham, Alabama, including all age groups, ethnicities, and cultures. Patients with multiple disabilities and diseases will be included in our patient population as well. The professionals that are making this possible include 1 clinical care coordinator, 2 registered nurses, 2 women's health advanced practice nurses, and 1 collaborating physician. The processes used to assure success are essential. Patient flow, documentation, and recording which processes work and which create delays are crucial. Monitoring patterns that may cause complications will also be done to determine opportunities to help improve time management. The macro system consists of things that influence and sometimes support patients within the environment, such as culture, economic patterns, laws, customs, society, and nationality. The assessment and treatment for the patient's mental and emotional needs are just as important as their healthcare issues and will also be addressed properly. The mesosystem relates to the relationships and channels of communication between the different macrosystem factors that impact an individual. The state of Alabama has 8 continuums of care organizations that coordinate services for the homeless that the Mobile Medic for Women will utilize and collaborate with. A domestic violence resource is also in place for assistance, as well as homeless service groups, food banks, legal assistance, Social Security offices, United Way, and job training. Our mobile health clinic will focus on the homeless and poor families of any ethnicity or race that are generally in the childbearing age, but not limited to that age. We found some interesting statistics to aid our decision to focus on this special group. As of 2013, there are an estimated 4,689 homeless people in the state of Alabama. An estimated 858 of these people are chronically homeless. Women and families represent the fastest growing groups of the homeless population nationally. Approximately half of the homeless population are families with children. Among homeless families, 90% are female-headed. A young, single mother responsible for raising her child or children without family support and material resources typically heads a homeless family. Nationally, 20 to 50% of all homeless women and children become homeless as a direct result of escaping domestic violence. According to a needs assessment of the homeless population of Birmingham and Jefferson County in 2005, 40% of the population was considered hypertensive, with 19% currently untreated. With this high rate of hypertension, it is not alarming to also find that heart disease is the leading cause of death in this area, followed by cancer and cerebrovascular disease. There is also a high rate of sexually transmitted infections in this area. The Jefferson County Department of Health reported 275 cases of syphilis in 2010, a chlamydia rate of 653.4 per every 100,000 individuals, and a gonorrhea rate of 293.5 per every 100,000. Also, there were 174 women tested positive for hepatitis B, with 29 of them being pregnant at the time. This is an account for the entire population of Jefferson County. The STI rates of the homeless population were not specifically listed. However, 65% of the homeless population are sexually active, and 70% of them admit to practicing unsafe sex. It was also discovered that 40% of the homeless reported to have never used a condom. With those astounding facts, it is reasonable to suggest that the STI rates of the homeless are considerably higher and therefore a need for concern. The homeless have high rates of mortality and morbidity with limited access to primary care services. Among the homeless, 78% are smokers, 51% consume alcohol, and 84% have a history of drug use. One-third of them also have a mental illness, and 36% have considered suicide since becoming homeless. Along with poor nutrition and unsanitary living conditions, these morbidity rates increase the risk for numerous health-related illnesses that are faced by the homeless. There are also barriers to health care in this population. 60% of the homeless reported to having 1 to 6 health-related symptoms within the past month. 54% stated that they need to see the doctor but could not go. When questioned why they could not go, 67% said they couldn't afford it, 41% said they lacked transportation, and 11% said they did not know where to go. This lack of access to health care contributes to the many health disparities among the homeless. Homeless individuals are more likely to access costly health care services. A study published in the American Journal of Public Health estimated that the health care cost for homeless was $3.5 million, or approximately $2,000 per person. In addition, hospital stays of homeless patients are estimated to be 4 days longer and cost approximately $2,414 additional dollars per stay. With the excessive cost of treating the homeless, it is crucial to determine a more cost-effective plan in meeting the health care needs of this population. The homeless lack the resources to meet needs such as education, employment, living wages, and healthy food. This leads to discrimination towards this population due to the inability to meet social standards. Also, lack of transportation for the majority of this population limits their ability to change many of the outcomes of these determinants. Most importantly, health practices are poor due to the lack of access to health care and financing, which is influenced by discrimination and lack of transportation. The interprofessional health care team is composed of 1 clinic coordinator, 2 registered nurses, 2 women's health advanced practice nurses, and a collaborating physician. The role of the health care team is diagnosing, treating, and managing acute and chronic illnesses, attaining patient history and performing physical exams, ordering lab work and screening services, performing GYN exams, STD screenings, and Pap smears, and prescribing medications for infections and birth control. Also, they will provide family planning, GYN education, counseling, and other preventive measures, in addition to GYN referrals. It is estimated that 46.2 million people in the United States are currently living in poverty, with almost 25 million of those people being women. Women and children make up the fastest growing segment of the homeless population. They are at increased risk of homelessness due to domestic violence, poverty, and lack of affordable housing. The mobile health clinic allows women to have free access to GYN exams, STI and HIV testing, family planning, and health education. Mobile medicine units are aware of homeless populated areas and shelters, so the unit reaches out to those communities in order to improve access to care. Our unit will travel to the 3 homeless shelters for women within the Birmingham area, as well as the Jimmy Hale Mission and the Lovely Ladies Center. Methods of payments for the services provided through our project will include private foundations and corporations, Medicaid and Medicare reimbursements, and the Bureau of Primary Health Care grants. Alabama food banks assist in providing free or low-cost food, groceries, and perishable items in the state, and this in itself provides a healthier way of eating for our patients. The State Department of Senior Services is a program that assists senior citizens with receiving the medications that they need for free and finding additional ways to help with medical bills. The HCH program is a network of agencies that administer the McKinney Grant, which will support staffing to the Mobile Medic unit. Health fairs are held each quarter and newsletters are given to the hospitals, substance abuse treatment providers, as well as churches and community groups to help fund the services the Mobile Medic unit will provide, such as funding for lab, equipment, medications, educational material, supplies, and payment for the services that the staff provides each day. Mobile Medic for Women is intended to be a nonprofit organization. The Division of Federal Assistance offers a USAID nonprofits to improve health care access for the medically underserved, totaling over $1 trillion for a 3-year contract. For this purpose, we will use that figure for a $366,666 a year budget. Based on the average female homeless population over the age of 10 in Birmingham being 400, with the hopes that we can see each twice a year, that will average 800 visits per year. Based on that number, the money would be allocated at 49% for employee costs, 27% for patient care, 13% for transportation, and leaving 11% for incidentals throughout the year. Sustainability and stabilization of the organization is the main concern. Having the financial means for startup is one thing. Having the financial means to continue the program after the 3 years is another. Having a strong grasp on the coding and billing for Medicaid, Medicare, and disability is a must for receiving maximal allowed reimbursements. Open communication between billing and the staff is imperative to provide correct charting for this purpose. The McKinney Grant will help with maintaining the transportation needs of the program. Hopefully, after maintaining a measurably effective program for 3 years, a reputation would be established that would influence further donations from organizations such as Healthcare for the Homeless Incorporated. It will be a responsibility of all the employees to facilitate these connections for program stabilization. Mobile medicine is a new innovation to healthcare that is increasing the availability and continuity of healthcare services provided throughout the nation. There have been several services provided in this format, such as Mobile Med, created in Washington, D.C. over 40 years ago by psychiatrist Dr. Herman Myersberg and pediatrician Dr. George Cohen. Myersberg and Cohen were motivated to develop a more convenient way to provide health care to poor children and their families whose jobs provided no health insurance. The first clinic was stationed in the basement of a Methodist church and then soon relocated to the First Baptist Church, where it remained for over 30 years. It was Myersberg and Cohen's dream to further advance their services and expand their ability to reach more individuals through a mobile clinic. Myersberg stated, "If we had a clinic on wheels, we could go anywhere we were needed." After funding was in place, the services provided became mobile, and Mobile Med was created. The proposed Mobile Medic for Women is similar to what Myersberg and Cohen developed to service poor children and their families. The Mobile Medic van is to serve the homeless population of Birmingham and is modeled after similar services that are already in operation. However, this innovation will focus on homeless women and their health care needs. The unique care that homeless women require in various areas of health will be the focus of this project. Success is measured in many different ways and by many different types of people and personalities. Respect is the number one aspect to focus on when providing any type of health care. Also assuring that each individual involved attains a great deal of cultural competence. In order to provide a successful outcome when dealing with patient care, a great understanding of the variety of cultures is necessary. Safety metrics are used to measure safety within our project. Data related to safety metrics of a patient can be used for a variety of purposes, including the selection of improvement initiatives, measurements of the success and safety improvement efforts, enhanced transparency, organizational accreditation, and reimbursement. Irrational measures can lead to poor decision making, which can result in the loss of community cost. The quality of care is another great metric that measures success in any given patient. A set of patient quality and safety competencies will be used to measure the outcome of the care being given. Professionalism that will be provided by our service will increase patients' trust and confidence. This in itself will define a service safety metric for our project and will measure success as well. Utilizing the latest health informatics system will optimize chances of success for our clinic through improved patient satisfaction, improved patient safety, and faster processing of information. Electronic health records provide quick and reliable information necessary to guide clinical decision-making and produce timely reports on the quality of care delivered. Computerized physician order entry enables physicians to electronically transmit orders from a patient's bedside, which increases efficacy and reduces errors. Clinical decision support systems are general references, treatment protocols, and recommendations that can be tailored to a patient's unique data and can help improve efficacy of care delivered and reduce medical errors. Managerial decision support systems can be used to focus patient volume, project staff requirements, and schedule patients to optimize utilization of patient care. Each of these health informatics systems could be used to help the logistics, overall efficiency, and cost management of the mobile clinic. It is a real possibility that the mobile health clinic may not be able to open or stay open because of the lack of reimbursement from the federal government, especially in the state of Alabama. The Affordable Care Act is supposed to supply millions of Americans with insurance, but a big hurdle may exist for the homeless population. Receipt of public health benefits among the homeless is low, and these numbers remain low because of federal restrictions that prohibit federal help to those without a physical street address. If a law to counteract this physical address issue is in place and the mobile clinic is guaranteed reimbursement from the government, our clinic will have success in the Birmingham area.